Hello and welcome to this edition of Central Connecticut Now, the program that brings you closer to the people that make the news in Central Connecticut and those that cover them. I'm Mike Schroeder, publisher of the New Britain Herald and Bristol Press, and today my guest is going to be Kurt Barwis, CEO and President of Bristol Health. He's leading the charge in the Bristol area and on all of Central Connecticut to deal with this pandemic in the hospital and outside the hospital, as he'll share with you. Kurt, welcome to Central Connecticut Now. I know that you're up to your eyeballs in work dealing with the COVID pandemic and dealing with it from a hospital perspective and as a patient most recently. And we're so thankful that you've come through it with 100% back at work after a time of quarantine. What are your biggest priorities right now?
So thanks, Mike, for saying that. I'm really happy to be back, and I really appreciated all the people that reached out to me and wished me well, and going through the recovery. And it's been incredible to be in a community like this where the whole community's around you. I mean, literally, it's been an incredible journey for me. And so right now, I think the priority is safety. The priority is the safety of our patients, the safety of the folks that are taking care of those patients when they come through the door, making sure that everybody understands and has available the appropriate protective gear to take care of these patients. And I think, in that list of high priorities is also the need for testing and some of the issues that we have around testing. You published over the weekend that we've limited our hours or our time or the number of tests available to 40 a day. We had to shut down today because of the high winds, and we were afraid that the tent might hurt somebody, blowing away. So testing is an issue. And then it's, the ultimate other thing that you worry about is, making it through this thing financially okay, just like anybody else. I mean, we've got a whole bunch of businesses in the community, which unfortunately have had to close down and furlough their staff. And so there's a whole bunch of people, that are supporting this whole process who aren't able to work. Unfortunately, it's not because they don't want to work, and they're out there as well. So, it's three things, safety, making sure we have the right stuff to take care of people, and we do that to the best of our ability. It's really focused on getting the right supplies to do the testing, and then it's the aspect of making sure that we go through all of the myriad of applications for the relief money, the FEMA money, and that we don't make mistakes, that we actually apply for the stuff, the payroll advance money, the tax stuff. It's every day we're getting new information about that. In fact, we actually don't even have the forms yet to apply for the $100 billion of hospital relief money.
Oh, goodness.
And they're being created. I mean, as you can imagine, it's and so we have to keep being able to supply, to get the supply chain going. So we have to pay suppliers, and what you're hearing and reading about and publishing about, the hyper valuation of protective equipment, N95 masks. I think I saw an article from New York where the guy was selling the N95 masks for $75 a piece, and they went in and busted the guy, and he was sitting on hundreds of thousands of masks.
Gosh.
And so every day it's we have a meeting at 2:00 every day, and we go through everything. We have our safety huddles in the morning. Twice a week, I meet with through the hospital association. I meet with all the hospital CEOs in Connecticut every Tuesday and Thursday. The Thursday, not last Thursday, but the Thursday before, the governor was part of that call. So the collaboration and the connectivity from a Connecticut standpoint has been incredible, absolutely incredible.
Do you, talking about safety, do you believe that you've got a pipeline to the proper PPE equipment that is necessary for the hospital? Are you running into any shortages?
We're running into all kinds of shortages, and we're, as a team, we're coming up with alternatives. So if we run out of gowns, for example, one of the things that's just really amazing is that, and I think you printed this over the weekend in the paper, but for a person who's tested positive to COVID in the hospital, we're going to run through 25 protective gowns in just 1 day's time. So at this point, we can't have enough of those things. We are trying all different approaches. Accidentally, one of the gowns went through the wash machine over the weekend, and it survived. And so we're actually, that plus we have a spray-on, thing that makes them sterile again that we're looking at. We've bought UV lights that will also sterilize certain things and sterilize rooms. So we are looking at everything and anything as a way of reprocessing. We're also taking some lessons, best practices from other parts of the country where they've extreme hotspots. And one of the things that we're doing right now is, so for a nurse to go into a specific room, if we can figure out a way for that nurse to hang up the protective material without somehow infecting themselves, and this takes practice. I mean, it's reminiscent of the Apollo program where they lost all their systems, and then back at NASA, they had a lunar module, and they were figuring out how, like, if we turn all these things off, how are we going to maximize?
And they throw everything onto a table. This is what they've got to work with.
Exactly.
Let's make it work.
And in general, healthcare people are really good at that. And I have to tell you, the team here has just been amazing. I just sat through the 2:00 briefing, and they talked about different approaches to, in one particular case, where they're using a specific mask. They're struggling to figure out how to get the gown off clean without, get it over this special kind of mask. And they may need to have two people to do that. And so, yeah, it's just every day we're looking at how we can source the materials. There is shortage of everything. We'll get a confirmation that something's going to ship on a certain day, only to get the 3M or whoever it is to call us up and say, we don't have a date for you today. So you're counting on it, and then you don't have a date. So
now, are you still on the top of the curve? Are we still seeing additional patients, additional fatalities?
We are
at the hospital.
I don't think we're at the top of the curve in Central Connecticut. I really don't. I think, and just based on the positives that we're seeing now coming through our testing site, we're running pretty close to 25% of the tests that we're doing are positive. Now, we don't screen for people out of the area, so we do have a fair amount of people coming from other communities. And then just on the daily reports you get, the feeds you get through the Hospital Association and from the governor's office, you can see that we're not there at the peak yet. And I'm not an epidemiologist. I'm not somebody who could predict readily, but I still think we're on the climb. I think that the area of concern is long-term care facilities. I'm hearing a lot about some long-term care facilities. Everybody's residing in that facility, and they don't necessarily go out, and so you have workers and you have the residents, and one person comes in, and the next thing you know, it's everywhere. And I know, in particular, from our own long-term care facility, we're working really hard. I know that others are as well, but I think that's where we have a lot of retired folks in Connecticut, right? We have a lot of senior people, and I think that's an opportunity for us to potentially miss really containing it, and that concerns me right now.
Have you had any positive tests among hospital staff yet?
We have. We have had a few, and hard to say. To go back and trace where those tests come from, but we follow the CDC guidelines and the Bristol Burlington Health District guidelines. In terms of screening, I'm an example of that. The guidelines changed from the time that I went out to the time that I came back. When I went out, the CDC guidelines were 14 days and 2 negative tests. The problem is there aren't enough tests to go around, so I think they changed the guidelines, and So it was 7 days from the onset of symptoms, and then 3 days of free from symptoms. I was actually cleared for work last Tuesday, but I chose to stay back home until Thursday, and I came in with a mask on and all the protective gear. By the way, I'm social distance right now, so I don't have a mask on, but I wear a mask at all times. Otherwise, it's hard to communicate when you're wearing a mask. So Chris is far away from me right now. I'm all alone in my office, and I do have ample cleaners here. I have this really fancy stuff, and when I finish, I wipe everything down to make sure I don't somehow spread the infection.
Hospital grade.
Hospital grade. They tell me I'm not supposed to. I've been using it with my bare hands, and I got a reprimand for doing that. I have to use gloves to use that stuff. But yes.
And this is, we talked about tests a bit before we went on camera.
Yeah.
And the various things various thoughts about that you have to field all the time. And you seem to have found a certain amount of misinformation out there about tests.
Yeah, true. So the tests that we use for the testing site and for our inpatients and employees are molecular tests, similar to what happens when you send them to Quest or LabCorp. And now we've acquired our own testing equipment. It's here now, and it's being validated, which is a 2+ week process that we have to go through before we can actually start to do our own testing. When we get finished, we'll be able to do about 3,000 tests a week if we were to run 3 shifts full steam. But those molecular tests are the most accurate. So in terms of accuracy, the testing equipment that we bought is about 99% accurate, and it's proved to be that way. That testing equipment will turn around a test in between 2 and 3 hours.
Now, is that the swab test? Or
that's the one. It could be a nasal, it could be a throat, it could be saline. There's a bunch of ways to actually to get the sample from somebody. All of those things, all of those swabs, whether it's a throat or a nasal swab, are on back order. This week we received just 100 of them. We received 100 this morning. So when you think about what we've done, we're doing 40 a day on the testing site. We have to reserve enough for our inpatients, emergency room patients, and employees to be able to deliver care. So that's why we limited it. So that's an exact or a direct test of COVID-19. So a molecular test, direct test. The Abbott test that everybody keeps talking about is also a direct test, and it's a rapid test. Now, the information that has been published says it's about 95% accurate. So it's really up there in terms of accuracy. But understand that it went through an accelerated approval process with the Food and Drug Administration. So we have those machines. We have the mobile testing machines, or I forget how they call them, mobile testing units. We have 2 of those. So if we were to get shipped the cassette or the actual Abbott test that the actual cassette to actually perform the test, we have the equipment in-house here ready to go, and we could do those tests. We've tried repeatedly to acquire those cassettes, and there's one cassette per person per use, and we've not been able to get those. It's not available to us. So I think, and I've seen this on the news media, that Abbott prioritized certain geographic areas. Some people tell me that they think it's prioritized on hotspots. They're shipping them to where the hotspots are. And then I've heard other people say they were shipping them to where the hotspots aren't yet. So I don't know what's right or wrong. All I know is that we've tried repeatedly to get the Abbott equipment. We have the equipment. What we've been trying to get is the test cassettes or cartridges, and we've been unable to get those. Now, what we have, what the state has, what the big lab are the molecular testing, and it's a direct test of COVID-19. So it's the most accurate way to figure out whether somebody currently has it or not. There's also now the ability to test for the antibodies. So So I've tested positive to COVID-19, and so my body fought off the infection, and so to do that, I built up antibodies to ward off the infection, right? So if you test my blood, you will likely find antibodies that will be strong in fighting COVID-19. So there's about 70 companies now that have applied for and received expedited approval. And in fact, the Food and Drug Administration said, this is simple technology, and it's pretty easy. So they just approved all these companies, or let these companies start to market it. Whereas if this wasn't an extraordinary time, they wouldn't have done that.
Sure.
So the FDA's commissioner just went on record saying, and actually the gentleman who represents the Public Testing Foundation has said it's kind of a wild, wild west when it comes to these antibody tests. It's not, you don't know which one's accurate, which one's real, which one's good, because they haven't gone through the rigors of FDA testing.
Got it.
So, and it doesn't tell you if you have it. If you have COVID-19, what it does is it tell you is if you had it by way of having the antibodies present. And remember, COVID is the common cold too, right? So
sure,
it is not the most reliable way of getting at, first of all, do you have it? No, it's not going to tell you that. Did you have it, and do you have antibodies? Yes, but those antibodies could be for COVID-19 or the common cold. So,
got it.
So that's the other thing. And so I feel a bunch of questions every day, like, how come we don't have this, this Abbott test? We have the equipment. We just, everything's on back order. They're not shipping them into our area, and maybe they will soon. Our equipment comes online, and like I said, we'll be able to do upwards of 3,000 tests a week.
It must be frustrating to have, like owning a camera with no film in the old days. A lot of good it does you, right?
You're so right. You're so right. I had a lot of time in my home office, and I actually found some old rolls of Kodak film, and I'm thinking to myself, and I was cleaning out, and I still have old cameras that you develop pictures, and I'm thinking to myself, I wonder what's on this film.
What's on those things?
I have no idea, but it's just really funny to me when the example you used. It was something I thought about.
And do you think that you're going to be in a position, we know that financially this is going to take a toll on the hospital.
Yeah.
You've already had to have a pretty good size layoff to deal with things. Do you think that you're going to be properly compensated to pay for this, all the extra work that had to be done?
That depends. One of the issues, Mike, and I've been going back and forth with the president of the American Hospital Association over the weekend, Rick Pollock. So about 30% of the money that was allocated, there was $100 billion for hospitals to try to get them into a place where they can continue to make the investments. I mean, we've made extensive investments in retooling our facility, but that money was supposed to flow very quickly, very fast. And the Hospital Association, the American Hospital Association, said, look, the easiest way to do that is to allocate it based on the number of staff beds. So it was something like, you were going to get $25,000 per staff bed, or even probably a higher number than that. Ultimately, what the government did was they allocated the money based on Medicare fee-for-service payments in the past. So we haven't gotten our check yet, but what I'll tell you is that they excluded Medicare Advantage payments or Medicare Advantage plans. So by doing it the way they did, we will get shorted because we have high degree of Medicare Advantage. I call it Medicare Disadvantage plans in our community that we're basically going to be shorted as an organization to the tune of about 50% of the relief money we would get, because people have picked these Medicare Disadvantage plans. So, I went back and forth with Rick Pollock over the weekend, and he assures me that, they're advocating in Washington and saying, look, this wasn't the way to do this. And there's two reasons for that. You have hospitals that are heavy inner city hospitals that have a high percentage of Medicaid patients. Well, they got shorted because they don't have as much Medicare. And then there's hospitals that have heavy penetration of Medicare Advantage, or disadvantage, as I call it, and then we got shorted because of that. So I don't. The answer to that question is I don't know right now. We are taking advantage of every single thing that we can, but on the first round, the first 30%, I know that we got about half because of these Medicare Advantage plans in our community.
So were you in a situation where you had planned for this reimbursement and then it's not coming?
Well,
based on that formula?
Yeah, half of it's not coming. We weren't aware until last week, because we were very pleased with the initial suggestion from the American Hospital Association to the federal government. Look, to be fair to hospitals that are, so take, for example, children's hospitals, right? Children's hospitals are very heavily, they could have 80% of their patient population as state Medicaid patients, right? So now all of a sudden, if you say it's going to be based on, Medicare fee-for-service payments over the last year, well, they have the very low percentage of that. So, and they're just as, at risk right now as we are, even more so, because they're relying on those Medicaid payments. So, anyway, yeah, but I think it's too early because, Rick Pollock, wrote me back and said, Kurt, we are advocating for an improvement in the formula. Right now, it's only 30% of the money was put out. The intent was to have that money come quickly. And I think they felt like that was their way of getting some of it out quickly. Hopefully, there'll be a much more sophisticated formula that's gonna work. I spoke to John Larson, called me last week or the week before last, and talked to me about what to expect. And I don't think that our federal delegation is fully aware that we were shortchanged because of the Medicare Advantage penetration in the state of Connecticut.
They don't think that you were shortchanged, or they?
I don't think they're aware. I think that's something that I need to do, and I'm going to do is make them aware that the allocation was not optimal. Needs to be adjusted to reflect a bunch of factors that it's not reflecting. So, if you're in the state of Massachusetts, it's a home run because they don't have these Medicare Advantage plans up there. So they got fully allocated. They got their money fast. So just an example.
Well, we know that you are up to your eyeballs in a very important issue of taking care of our own and your own. And we hope that, we're glad that you took a minute to share with our folks, gave them a little education on a lot of the things that are going on with this pandemic. And we hope that soon we'll be able to talk again. You're almost a regular host on this show. So I'm looking forward to the next time we see you, Kurt, and it'll be under better circumstances. And hopefully it'll be face to face.
Yeah, so, stay safe, Mike. Stay safe and sound.
And thank you. And thank you for tuning in to this edition of Central Connecticut Now. We hope you'll tune in again next month when we'll have another guest that is on top of the news and being covered by the news. Take care.